Thank you. Thank you, Costas. Thank you, chairpersons. I'm very happy to be with all of you again, and I'm hoping next time face to face. Thank you for inviting me to these traditional meetings, which our countries have more than 2 decades. In small cell lung cancer, we have a progress in the last 2 years. In the last 2 years, there were two great studies. One is Empower 133, and the other is Caspine. Both were promoted in 2019, and both have shown a significant prolongation of progression-free survival using the immunotherapy. In Empower, we have the standard protocol plus atezolizumab Tecentriq, and in the Caspine study, we had shown a great progression in progression-free survival in patients who underwent standard protocol and Invisi, actually durvalumab. These studies have shown the progress in the extensive stage of small cell lung cancer. As there was a dark for 20, 30 years, we had the same protocol. Now we have a new biomarkers in small cell lung cancer, and we are waiting for the further improvement in the immunotreatment. Before biomarkers, we had standard protocols, as it was seen that small cell lung cancer is molecularly heterogeneous, differences between small cell lung cancer subsets. We have get new chances for a lot of trials and new options for the treatments. We have the news in standard protocols. In NCCN guideline, we have a primary therapy for extensive small cell lung cancer, where we have a standard protocol, carboplatin etaposide plus atezolizumab, followed by maintenance atezolizumab, and the same with durvalumab, the standard protocol, carboplatin plus etoposide and durvalumab, and followed by maintenance durvalumab in the next 28 days info cycles. So a great progress is seen in these treatment options for extensive small cell lung cancer. In relapse small cell lung cancer, we have a preferred regime with topotecan, lurbinectinib, and still we have a lot of clinical trials. But recommended regimes are with the new options with immunotherapy, nivolumab, pembrolizumab, temozolomide, and other possibilities. Empower study was designed in two arms. In one arm, we had patients with extensive small cell lung cancer who underwent atezolizumab plus carboplatin and etoposide, and each 20-day cycles, it was repeated 4 times, and maintenance was atezolizumab. The patients were treated until progression of disease and loss of clinical benefit. The co-primary endpoints were overall survival and progression-free survival, and key secondary endpoints, objective response rate, duration of response, and safety. And we had shown a great progression in progression-free survival. Median progression-free survival was 5 months, 0.2 in arm who underwent standard protocol plus atezolizumab, and hazard ratio was 0.77. We can see in these curves that 30.9% of patients had the 6-month progression-free survival, and in arm who underwent atezolizumab, it was 22.4, and the most significant option is in 12 months progression-free survival, where we have a 12% of patients who were in this group But in the group who didn't was treated with immunotherapy with atezolizumab, we had just 5.4. Overall survival was in patients, median overall survival, who underwent atezo plus standard protocol, 12.3 months, and in placebo group it was 10.3. And we can see how nice is the difference among curves. In 12 months overall survival, there were 51.9% of patients, and in the group who underwent just the standard protocol, 39.0. Side effects were mostly hematological, but not so strange. And in background, you can see that atezolizumab and carboplatin can get improvement in patients who are treated on this way. And in March 2019, FDA took it as a standard protocol, and EMA in September 2019. The SPINE study has shown the similar results with durvalumab. We have patients who underwent standard protocol plus durvalumab and placebo group, and then after treatment maintenance with durvalumab. And primary endpoint was overall survival. Secondary endpoint was progression-free survival, overall responsibility, and safety and tolerability. In overall response rate, we can see that patients who underwent standard protocol plus durvalumab had advantage, 22.7%, due to patients who had just EP protocol, and their response rate was 6.3. Progression-free survival in patients who underwent durvalumab was 5.1, and EP it was 5.4, hazard ratio 0.78. Overall survival in patients who underwent EP plus durvalumab was 13 months, and in a group who underwent just standard protocol it was 10.3. It is hazard ratio 0.73. First line durvalumab plus etoposide and carboplatin demonstrated a statistically significant improvement in overall survival compared with the control arm, which followed just 6 cycles of EP. And overall survival was in hazard ratio 0.73. Clinical benefit was also observed across progression-free survival and overall response rate, and the safety findings were consistent with the known safety profiles of all agents received. A combination durvalumab with cisplatin or carboplatin etoposide in extensive small cell lung cancer provides an important new treatment option for patients and for physicians. The study keynote 6.4 was analyzed patients with extensive stage small lung cancer. It was a blind study. We have two arms. In one arm, there were patients who underwent standard protocol plus pembrolizumab, and in the other arm were patients who underwent standard protocol plus placebo. And the median months were in a group with pembrolizumab, 15 point progression-free survival was 15.9, and in a group with standard protocol it was just 5%. Hazard ratio among these two groups were 0.73. Overall survival also was significantly impressive. In a group who underwent Pembra plus EP, it was 10 months, 0.8, and in a group with standard protocol, it was 9.7. Hazard ratio 0.78. Also, adverse events were just hematological, and it was not so strong as it could be in chemo treatment. We have other protocols also in patients with extensive small cell lung cancer. A lot of news, combination with standard protocol with nivolumab, and followed by maintenance as nivolumab. There are also progression-free survival was with hazard ratio 0.68 and months 5.5. Overall survival in a group with nivolumab was 11.3 and hazard ratio was 0.67. Nivolumab as a monotherapy in relapsed small cell lung cancer was analyzed in checkmate trial 032. Progression-free survival was 1.4 and the overall survival was 5.6 months. Lurbinectedin is second-line treatment in the patient with small cell lung cancer. In the patient with relapsed small cell lung cancer, it has shown improvement in progression-free survival and in overall survival. We can see that patients who are in a resistant form of relapsed small cell lung cancer, the progression-free survival was 2.6 and in sensitive it was 4.7 and overall survival in resistant group was 5 and in sensitive group it was 11.9. Also, lurbinectedin had shown in a second line a good overall response rate. It was confirmed in patients with stable diseases. There were 35%, in partial response 37%, and progression was seen in 28 patients. No response was in 5 patients. It's important that duration of response in sensitive patients was 6.2 months, and in resistant patients it was 4 months, 0.7. Lurbinectedin is an active single agent in second line of small cell lung cancer, and anti-tumor activity is notable in sensitive disease. Overall response rate of 45%, as well as in resistant disease. Overall response rate was 22%. Lurbinectedin has a favorable and manageable safety profile and is well tolerated. And it is a new treatment in a second line of small cell lung cancer patients. There is a study with alnotinib in advanced small cell lung cancer in a patient who underwent in the first line chemoradiotherapy, and they were analyzed in 2 groups, alnotinib with placebo. In a group, progression-free survival was analyzed, as well as overall survival, overall response rate, and of course quality of life. And also it could be seen a significant progress in progression-free survival in the group with alnotinib. Comparing with the group with placebo, it was 5.49. Also, overall survival was significant, important in this group. It was 9.49 in comparison with the group who underwent placebo, where it was 4.89. Progression-free survival and overall survival in small cell lung cancer patients who were in the first line under chemoradiotherapy under alnutinib, comparing with placebo, was significantly progressive, and also a safety profile was seen in a group who underwent alnutinib. Also, we have trials with apatinib. Apatinib is a combination with chemo and maintenance treatment, and the primary endpoint was overall survival and progression-free survival, which was seen as a prolonged comparing with the patients under placebo with hazard ratio 95%, P0.002. We have also some new data with ROVA-T program in small cell lung cancer, and the median duration of response rate was 4.1 months, and overall survival was 5.6 months. There is a progress in new drugs. There are new study design with veliparib. Patient received 4 cycles of treatment and then 2 cycles, and every 3 months after the end of the treatment. Also, all these patients were under PCI. PARP inhibitors have shown also important signal of improvement in the treatment of extensive form of small cell lung cancer. Due to all these data, I would point to the home message. Until these medicaments, the first-line treatment in extensive stage of small cell lung cancer has been the unique for all patients, and it was just platinum doublet, and it was with combination with the etoposide or irinotecan. In the past 2 years, we have phase 3 trials which demonstrates the clinical benefit of adding immunocheckpoint inhibitors to frontline chemotherapy for the treatment of extensive stage of small cell lung cancer, leading to approvals of atezolizumab and durvalumab in this setting, what was confirmed by FDA and EMA in the standard protocols. Of course, we need novel treatments, novel chemotherapies, combinations with immunotherapy, but I'm hoping the next generations of biomarkers will be helpful in this edition. Thank you very much for your attention.
Thank you very much for your excellent presentation, Ivana. We left the questions after the end of the